Hello, everybody. Again, this is Dr. Al Heuer. I am a professor at Rutgers School of Health Professions for a long, long time, co-owner with Terry Shenfield of A&T Lectures, and I do a bunch of other things, including still take care of patients at the bedside in a large hospital, acute care hospital in our area. For the next 50 or so minutes, I'm going to be covering a topic related to COVID's impact on the healthcare workforce. So as I dive into this, let's look at some specific learning objectives. In this presentation, we'll define and distinguish amongst key terms, including burnout and post-traumatic stress disorder, or PTSD. We'll actually talk about this terminology, let's say pre-COVID. So this is not these terms are not specific to COVID, as you guys could well discern. So we'll talk about, but we'll also kind of tie into the notion of how and in what ways, the COVID pandemic did and still has contributed to burnout and post-traumatic stress disorder. We'll describe the prevalence of burnout and post-traumatic stress disorder in our healthcare system pre-pandemic, and then really focus on, ways in which it may have contributed. The COVID pandemic may have contributed to it. Compare some strategies to potentially mitigate workforce burnout and PTSD in general, and maybe some of those related to COVID. And we'll also furnish you with additional resources if you want to drill down and learn more about this topic. So some of the key terminology, I originally had even more terms in this, and I really focused on, let's just really focus on what's key to this presentation, and really occupational burnout. So sometimes people use the term like, I'm burnt out. That could mean I had a burnout day or a burnout week type of deal. Other times when we're talking about, occupational burnout, we're really talking about individuals who are really feeling the strain from a sustained pace that's just, it's too rigorous. And maybe it's the pace at work combined with the pace at home, and responsibilities of taking care of kids and meeting budgets, but at the same time having to deal with the work stress and the personal stress and things along those lines. But occupational burnout is really something that's really focusing much more on the extent to which the professional obligations, the work obligations, et cetera, will actually contribute to it. So feelings of energy depletion or exhaustion can be one of the, if you will, key symptoms. Increased mental distance from one's job, feelings of negativity or cynicism related to one's job, reduced professional efficacy. Just not as they're just not as productive. They're more irritable. They're just maybe they're getting in, not just having conflict with patients and families, but maybe with coworkers and things along those lines. However, occupational burnout is in and of itself not a diagnosis. Okay, there's not an ICD-9 or ICD-10 code or 11 code for occupational burnout. On the other hand, post-traumatic stress disorder is potentially a mental disorder, okay? And when used officially, not used in a colloquial sense, that it's a mental disorder that may develop after an exceptionally stressful or threatening period of time, event or events. Can occur a single traumatic event or from prolonged exposure to various forms of trauma. Some of the other characteristics are described here as well. But another related but different term is secondary traumatic stress disorder. That's really a form of PTSD occurring in caretakers, of those that are within the immediate proximity and perhaps actually taking care of that individual. Those who've basically taking care of those who've experienced traumatic events themselves. So that in and of itself can actually be a form of trauma. Brief history on burnout. Let's take a look. So it's not a new phenomenon. 1961, Graham Greene novel, A Burnout Case, really talked about a doctor working in Central Africa, in what was then the Belgian Congo, with patients that had leprosy. So there's basically a leper colony. And these individuals needed a lot of care, and it was pretty constant, and they were very vulnerable, and they didn't have a lot of money, and there was a lot of them that were sick, and they were concentrated in one area. And really talked about, the disease, leprosy, that, basically it's a disease that actually can be treated now. But back then it was just, lepers were put in colonies, and they had big sores on their body that would spread, and ultimately necrose, and it was a bad situation. So these individuals, as I said, needed a lot of care, and the doctor taking care of them experienced burnout, and talked really about the burnout. 1974, Herbert Freudenberger, did not make that name up, really his name, an American psychologist, used the term burnout in his scientific article, Staff Burnout. So now we went from 1961, an individual talking about, a physician individual talking about his treating patients that had leprosy, to mid 70s, basically a psychologist talking about burnout in the context of staff. Okay. 1981, Maslach and Jackson published an instrument for assessing burnout. We're going to talk more about that. It is known as the Maslach Burnout Inventory. It's basically the first such instrument of its kind, most widely used, and it really focused on human service professionals, teachers, social workers, et cetera, et cetera. Also, again, police officers, healthcare workers, et cetera. 1990s, the WHO adopted a version, a conceptualization of burnout that is consistent with Maslach's. Although the organization does not treat burnout as a actual mental disorder. Let's kind of tie into a little bit of what's really going on in America regarding, they talk about the individuals, the mass quitting. Okay, people just not coming, getting laid off and not coming back to work. It's a big deal. I read about it all the time. Basically, everybody's looking for jobs. It's not just nurses, respiratory therapists, and doctors that are in great demand, but basically, plumbers and folks that pour your coffee and serve your toll collectors, etc. So a lot of individuals are quitting their jobs. It's not fully understood, but they're really thinking that there's a lot of things going on before COVID, and COVID has certainly contributed to it. Even if you're not in healthcare, the isolating effects of having to work in front of a computer for 4, 5, 6 days a week, for 8 hours a day, whatever the case may be. Some apparently found it to be dehumanizing, and some felt that there was no separation of family and your profession, so you're kind of like on call all the time. That and just adding, not icing on the cake, but adding to a foundation of dissatisfaction with jobs, before COVID and things along those lines. So the Bureau of Labor Statistics indicated that a record-breaking 14 million Americans across a variety of industries quit their jobs in 1 month. That's the highest number since they began tracking in 2000. Food service, retail, and no surprise, healthcare industries were most hardest hit. Talked about over 500,000 U.S. workers in healthcare and social assistance positions resigned or quit. We're not talking about people that retired. Some of them actually retired. Okay. Again, one of the other presentations that relates to stress management in the context of COVID really talk about, we may well have some nurses that hopefully we do that have attended today's session. But the number of respiratory therapists and the percentage of respiratory therapists that are estimated to retire over the next 8 years, it's like we have 140,000 respiratory therapists in this country, in the United States. Okay. They're talking about 80 to 90,000 of them are going to retire in the next 8 years. Okay. It's a crazy number. And on top of that, on top of the 140, if none of them retire, they estimate that there's going to be about a 20 to 25% increased need for respiratory therapists. So this is just it's a scary situation there. Okay. But really, on top of all that, we're talking about over 500,000 workers in healthcare and social assistance resigned or quit. They quit. And we're talking about August of 2000. According to Mark Zandi, chief economist from Moody's. So he's well-renowned dude. If any of you guys watch Squawk Box or any of these financial channels early in the morning or in the evening, whatever, Mark Zandi is frequently on there. Workers now have the opportunity to exert pressure on their employees. We're now seeing a labor market that is tight. Prospects are becoming increasingly clear. And one of the things that's going on. So we're talking about this whole presentation is related to COVID and the workforce. And it's really interesting to see because as I talk to my colleagues I'm a Jersey boy in New Jersey, but throughout the country, my AARC colleagues, my healthcare management colleagues, my respiratory therapy colleagues, et cetera. Okay. It's that it seems like still a lot of healthcare organizations they're slow to adopt effective measures to retain employees. They seem strangely willing, not happily, but willing to pay travelers $110 an hour and the agency $160, but the individual and do not a lot, not nothing, but not a lot to retain staff. So it's an interesting time, whereas other industries seem a little bit more ahead of the game on being more proactive to retain staff. It's like healthcare leadership is kind of struggling. They're not leading. They're not doing a good job of leading in some organizations. Interesting thing to see, really. In any event, so Zandi was basically saying starting to collect their collective muscle. So flex their collective muscle. In healthcare, maybe not. We've seen, not a huge rise in unionization. I frankly would have thought there would have been a higher rate of unionization. But in any event, that's a topic that that I touch on later in this presentation as well. So let's get back to Maslach, the burnout survey. So quickly, its characteristics: 22 items, individual item ratings. From no burnout to 6. So from 0 to 6. Total score of 0 to 132. If you just do the math, it works out. Again, designed for professionals that I just mentioned earlier, focused on helping people live better lives by offering some guidance, ameliorating some of the physical, emotional, and cognitive problems that can occur. I'm not going to read this slide to you. But I did want to just give you actually 22 items. So these are the 22 items. Not going to read it to you. But I'll just look at the first and second one. I feel emotionally drained from my work. I feel used up at the end of the workday, etc. Used up. They're not saying I feel like I'm a little tired or whatever. They're talking about drained, using extreme terminology here. And again, rate it 0 to 6, and you come up with the total coefficient there. So the related response of prolonged stress and severe stress. PTSD, burnout, depression. I could have put a circle in there for anxiety. Anxiety is not the same as depression, but you get the idea. Some patients can have all of the above. Okay. There's actually a fairly high predilection of folks that have post-traumatic stress disorder and depression. They tend not to be highly functioning. They tend to have high absenteeism. They tend to jump from job to job. The substance abuse, smoking, et cetera, they tend to be a greater, shouldn't use the term burden on our healthcare system, but they utilize our healthcare system a lot more than folks that don't have it. So there's this overlap in some cases, but they're not the same. They're not the same thing. PTSD, burnout, depression, anxiety. Healthcare workers are more predisposed to stress and its consequences. Not a new thing. This is talking about 10 years ago. Shift work can be very difficult. I only worked nights for, about a little over a year, and it was just hard on me. I work with people who work nights, and it wasn't hard on them. They preferred nights. So everybody's different. A lot of people that I talk with shift work, particularly if it's rotating shift, can be very, very difficult. Working holidays and weekends, every other weekend, most places work. Healthcare is one of the most complex industries. So really it's, third-party payers, you have, high rate of obsolescence, and technology development, things along those lines. Just a lot of dynamics going on. High stress of just the work overall. If you work, by the way, you can work in acute care, it'd be very high stress. You can work at home care and it can be high stress, and you're driving, 200 miles a day. So you get in a traffic jam, you got to be, in two people's homes, and at 3 o'clock and 4 o'clock, but you're stuck in traffic at at 2:45, and you're not going to get there, and you got to reschedule, and that, lions and tigers and bears on mine. So it can be, life and death situations. It can be being understaffed, which a lot of places are today, leading to heavy workloads, or it just could be heavy workloads, period. That your organization has always been very, has been very light when it came to staffing. Dynamic environment. So, a manageable assignment can quickly change. You're like, I feel pretty good today. And then all of a sudden you get, 2 intubated patients, you got running around. Whatever. Disconnected leadership. Doesn't happen all the time, but some leadership in some places is tone deaf to bedside care. They just don't, some organizations, the leaders, the managers, they put on scrubs, at least twice a month, once a month, whatever the case may be. They take an assignment. In some institutions, this doesn't happen. It's a cultural thing. It does not happen. So it leaves the organization at a disadvantage. It leaves those who are providing direct bedside care at a disadvantage as well, because you have this disconnectedness. Okay, so now onto the COVID part. How did COVID exacerbate things? Now that could just be one slide. We'll talk for the rest of the the remaining 30, 40 minutes. So, at first it was uncertainty, and it wasn't just uncertainty, but it was how contagious is it? Why does it make some so sick? Others, are basically spared. Heavier workloads, PPE shortages, equipment shortages, going in and, jury rigging, filters and this and that, rapidly changing protocols and procedures. And some of them were, my organization, I'm just being honest, my organization, I kept a diary, as I took care of patients, I had a diary. And at one point they actually put it on the website. We may consider, we're running short on PPE. We're going to consider bandanas. I have a screenshot somewhere or other, because it was so preposterous. It's like, you put on bandanas. I'm not wearing a bandana. I'm wearing a freaking N95 or a PAPR. Get me an N95 or a PAPR. And if you don't, I'll get my own, type of deal. But it's just this ridiculous stuff that was, being purported. More suffering, death, dying in the ICU. These patients died alone, many of them. I know, it's just the reality of it, but it was just like stressful, stress. Disconnected leadership, tone deaf to bedside care, because they rarely, rarely, if ever, were in the units, whatever. Support for long haul patients, but not for long haul clinicians. That's a whole nother thing. And I touch on that, several times in this presentation. Again, could go on and on about that, but I will, as I go through this presentation, I'll touch on some studies that talk to these specific issues, not in the context of Al Heuer being on a soapbox, but in terms of surveys that were done from different staffing departments and organizations that pointed to some of these things specifically. So more to come. COVID exacerbated things, so existing problem, if you will. So the supply and demand undulates. So there's a nursing shortage, the respiratory therapy shortage, and sometimes there's a slight surplus. It depends, whatever, at what point in the decade you are, what's going on. But again, these pre-COVID factors of shift work, high stress, things along those lines, and then the COVID related factors, that some of which I've listed there. And then, God forbid, it was just like, and then you had your kids that were, in school and they weren't in school, and you're dealing with that. And it just was stressful on so many fronts. So it's no wonder that it increased burnout, turnover, lower morale. And there's some alleged post-traumatic stress disorder that's emanated from it. I'm sure, and I'm not saying this lightly, but I'm sure that a lot of us on some level have some post-traumatic stress disorder from our dealings with COVID. And maybe our population is just, took the hit. And maybe we're seeing people's just getting tired of mask wearing and, whatever, and they just want to get away. They'll go on a plane. They just want to get away, type of deal. Perfectly, completely understandable. And then burnout specifically, not just in healthcare, but in respiratory care, is not a new phenomenon. So 1981, what was I doing in 1981? I was a year out of college, out of Montclair State College. Then it was college, now it's university, in basically about 15 miles west of New York City. Respiratory Therapy Journal. So now it's called Respiratory Care Journal. Okay, then it was called Respiratory Therapy Journal, featured a piece entitled Coping with Burnout in Respiratory Therapists. And the findings, so 1981, the findings, factors such as inconsistent on-the-job training, heavy workloads, lack of acknowledgement by other healthcare professionals contributed to it. And Pullen, was the one in 81 who actually published, wrote and published the piece. Not a new phenomenon. Research related to burnout and respiratory therapy. So Omar, I give the full citation at the bottom there, but in 2022, really looking, and he was talking about COVID, but it wasn't just a COVID thing. To report the prevalence of burnout, impact of, leadership, work condition, burnout amongst respiratory therapists in if you will, critical care settings. Studies suggest high burnout rate amongst RTs. Reported rate was significantly correlated to work conditions and leadership. Now, notice this isn't specific to COVID. They do talk about COVID, but they don't just blame it all on COVID, if you will, or attribute it all to COVID. Recommendations, not mine, theirs. Organizational efforts should be directed to combating burnout through the identification and adequate management of key precipitating factors. Okay, that's a whole lot of things. That's more than doing exit interviews, because if you should do exit interviews with your employees that are leaving, but that's too late. Okay, and it may help the ones that are staying, but better yet, find out from the ones that are staying, and find out from the ones that are staying maybe why they're staying, and if they're contemplating leaving, why they're contemplating leaving. So it's just, again, main finding there was quite interesting, not just to me, but others that I've shared this with as well. Now, this particular study looked at COVID-19 and the respiratory therapists, and it was actually ironically published a year before in 2021. It's an editorial review of related literature. Okay, the findings. So there was these fears that were existing, personal fears, becoming infected, infecting one's loved ones, which a lot of us experienced, even if you weren't on the front lines. You think you went out, you were, making phone calls to, family members on their test results, whatever, or you were, going out to ShopRite, whatever the case may be. But social isolation, emotional stress, social isolation is and was a big deal. I do a lot of work. I'm with you guys now virtually, but I do a lot of work. I edit chapters, and it's hours and hours and hours of isolation. I teach online, hours and hours and hours of, it's asynchronous, so I'm isolated online, type of deal. So I actually welcome, I'm a social person. I welcome the opportunity for sessions like this, and socially with, my friends and family, but also even, the work that I do now that I'm per diem in an acute care hospital. I really kind of enjoy it because, it gives me a chance to do what I write about and speak about. And it also gives me a chance to interact. And it kind of combats the time that I am, socially isolated, like I'm sure a lot of you are as well. Workplace fears, insufficient access to supplies, to PPE and equipment, ventilators, inadequate staffing paired with high patient volumes. One of my biggest fears, COVID first hit. You're going in and out of these rooms. Now we're a little bit more cavalier with going in and out of the rooms, going in and out, donning and doffing, was being in a room and knowing I could fix a equipment problem, but not having it and not being able to get it. Using, a Flow-Lon, needing more expiratory filters because these ones are getting clogged, and knocking on the window and not having somebody come and give me, get me more filters, that sort of a thing. In any event, Evans, 2021 talks specifically about this. It would be another one of those, I don't say a must read, but I highly recommend reading it. So a little more what Evans said. I'm not going to read this slide to you, but I do want to just quickly dance through some of the findings. So the majority of the survey respondents strongly agreed that burnout is a major problem, 93 some odd percent. Respiratory therapists have similar risk of burnout compared to other health professions, 92%. 72+% stated that they personally experienced some burnout. Again, just paraphrasing some of this. Not unlike studies of other healthcare professions, RTs report a high level of burnout within their departments when taking the survey compared to pre-COVID-19. So COVID-19 seemed like it was a precipitating factor. It was present beforehand, but it worsened by COVID. Despite high level of burnout, few respiratory therapy departments offer resources. We're talking about resources to combat burnout and post-traumatic stress disorder to the staff. That's an interesting finding. Like, why would you not? And there's a shortage. I think these people they're just done. I have to explain this all to you. It's too tedious. If I'm going to explain all this to you, I'm going to go, instead of making 40 or 50 bucks an hour, I'm going to go to an agency and make $110 an hour. And I won't have to explain anything. I'll just take the money and run. And I just, HR departments, they're not getting it as fast as they should. And, whatever. Could go on, but it is what it is. Only 10% of the respondents stated that the departments, they even measured. So we're not talking about addressing it. We're talking about measuring how bad it is. The survey that was done at our organization, 5 acute care hospitals, and it related to COVID, did not list respiratory therapists as a profession. So the results from the impact specifically on respiratory therapists could not be garnered because there was not a box you could check. Right there, I'm sorry, guys, failure of leadership. It's just the good news, they did a survey. The bad news is we were in the rooms the most, and they didn't even, they couldn't attribute the data, the results, to respiratory therapists because it wasn't asked. Just okay. 32% felt that leadership provided adequate support for experiencing birth. So 32%. I know what that means. That means that 68% did not. The most frequently identified key drivers of burnout included poor leadership, high workload, insufficient staffing, all in that 30%, give or take 30% range. This one focuses on this particular study, Rabinovitz and Rabinowitz, 2021, really focuses on women. And like it or not, when it came to the school thing, and I'm not saying men aren't involved, whatever, it was the kids, the school's closed, it's virtual, et cetera, et cetera. It was a lot of the women, the mothers, if you will, the wives, the mothers, were bearing the brunt of this more than the men. And this study really, looked at the pandemic disproportionately impacted women. Some of the more specific findings, while the pandemic has facilitated, several positive advancements in addressing these challenges, still much more work to be done for women. Address the equity optimal. So it wasn't just, stress and burnout. It wasn't just COVID stress and burnout. It's COVID stress and burnout, and then you're it. Okay, whether you're a single mother or you're not a single mother and you're just bearing the brunt of it. This study really kind of pointed to that in a significant way, and I can totally relate. Fear of COVID-19, psychological stress, work satisfaction, turnover, and tension amongst frontline nurses. So we really focused on RTs for the past several slides, but you can imagine it's not something specific to respiratory therapists. This particular study that was done by Labrage and others, De Los Santos. Basically, this study sought to examine the relative influence of the fear of COVID-19 on nurses' psychological stress, work satisfaction, etc. Overall, the composite score, 5 scales used, so different, to measure this level of, if you will, stress and distress of fear. COVID-19 scale was almost 20. Okay, job role, attendance, COVID-19 training, prediction of fear, COVID-19. Increased level of fear COVID-19 was associated with decreased satisfaction. Not surprised. The significance, middle part of the slide. Addressing the fear of COVID-19 may result in improved outcomes with frontline nurses. This one focused on nurses, but you could probably extrapolate this to other clinicians, including respiratory therapists. Organizational measures are vital to support the mental health of nurses. Okay, so this again pointing to nurses, but that's fair. And again, they get into this, the article gets into some of these sub bullets, what would be some of the features, etc. But time is going to preclude us from going too far down that rabbit hole. Costs of burnout. So, PTSD. The individual costs are dramatic. So physical and psychological debility, unwillingness of most clinicians to look after their own welfare as they look after their patients. So things like, substance abuse, things just like not taking care of themselves, weight gain. A lot of us gain weight, me included, but you could just watch, TV, some of the newscasters, it's just the same thing happened to them type of deal. So really not, it was very difficult during these real big spikes to, doctor's appointments and things along those lines were very difficult to be able to do unless you were doing them virtually. So some of the, the dental visits, the doctor's visits, the routine checks just weren't necessarily happening. That was circumstantial. That's not necessarily not looking after yourself. That's, that's just not pragmatically being able to do so. But now that, things have, quieted down somewhat, it's really time for individuals to kind of pick up the slack and, start taking care of themselves and the doctor's visits and things along those lines. So the individual, the higher levels of substance abuse, as I alluded to, undermining family dynamics, so further exacerbating the problem, lower levels of self-esteem, that if individuals, if they resign, if they left the job, lower self-esteem is, I'm leaving the job, I don't feel great that I'm not working, I'm not making money, or I'm on unemployment or whatever the case may be, but that's just further exacerbating it as well. Organizationally, the Great Resignation, the extraordinarily high turnover overall and in healthcare, including nursing and respiratory therapy, low morale and performance, higher levels of absenteeism, high cost of recruiting and training new employees. Looking at the retention versus the recruitment. Retention bonuses don't tend to work real well. Excuse me, I misspoke. The sign-on bonuses tend to not to work real well. Retention bonuses seem like there may be some efficacy there. High cost of agency employees, crazy. The more unionization, there's been some of that, but surprisingly not as much as some of us would have thought. Okay. Unemployment rate versus workforce participation. So looking at societal, see, when you look at the unemployment rate of being 3.5 or 6%, that does not account for people that have simply dropped out and stopped looking. So the workforce participation rate does include, I stopped looking, I'm done. I'm not really retired, I'm just done for now. Now they may not be done in 3 years, but they're done for right now. They're not counted in that 3.5 or whatever percent. Lower quality of healthcare. So that the overall that, if we have fewer doctors, nurses, and respiratory therapists and other clinicians, then at some point it's got to impact the quality of care that they're getting. The higher cost is dramatic. There are some hospitals that where these higher pay scales and of agency and travelers are having a dramatic impact on their bottom line. And some of them are operating in the red. Some of them are declaring bankruptcy. I mean, I feel badly, whatever. I don't know what to say about it, but there's things that can be done that aren't being done. Let me just say that much. And we'll talk a little bit about some of those things and some of the further studies that I cite will as well. Getting through COVID-19, keeping clinicians in the workforce. So Barrett, 2021, not my article, someone else's. And again, this particular article, I had to include this on 2 different slides because it was so jam-packed. Another article I would highly recommend. Okay. And really talking about the focus was risk of contracting COVID-19. So all of this, this stress, not just the risk of contracting, but just the stress that we've been talking about in these preceding slides. And the authors of this article urge employers and organized medicine take tangible steps, and they describe them. They describe several of them. Ensuring, so they really think about paralleling this with Maslow's, hierarchy of needs. Ensuring the physical safety by reducing clinician risk of contracting COVID-19. So let's just pause for a minute here. You think about the impact of us taking care of, so nurses, RTs, doctors taking care of patients that have COVID-19 and not having enough PAPRs and not having enough N95s, okay? Basic needs of safety. So Maslow talks about food, shelter, clothing. This is analogous for the healthcare professional. Having a mask and PPE is analogous to that. Okay, you need to feel safe. That's not enough to keep you, okay? It's what we call necessary, but not sufficient, okay? So one of the things, you got to make sure that you have that. You got to figure it out. You got to get it. You got to figure it out. What has happened, by the way, since 2020 is a lot of the sourcing, not just of PPE, but also of the disposables that were so hard to get during the initial pandemic, has been repatriated back to North America. So, has been repatriated. North America includes Mexico, by the way. Mexico, United States, Canada is North America, has been repatriated. So that's a good thing. But, my duck bill N95 is still very hard to get. I got to go back to my assistant managers, my hat in my hands. I got to bring, the favorite coffee to them, bribe them. I'm kidding about the favorite coffee, but they're still hard to get. That's what I'm approved to wear. So I don't want to sound like a poor me, but no, it's crazy stuff. Providing practical support in areas that clinicians identify as causing emotional stress. So that's not the bottom of Maslow's, but that's kind of in the middle of the scale there. All right. And just think about whether or not your organizations are doing stuff like that. My organization's doing something. We have stuff. We were doing some stuff, but it's very uneven. It's not clear. It doesn't seem like it's a well-woven strategy. It's a initiative over here and another one over here and another one over here. And then like the jigsaw puzzle, there's all these pieces missing from it. And it's not a cohesive plan yet. I'm hoping it will be. Provide sufficient time during clinical encounters for members of the care team to address COVID-19 vaccine misinformation. Extend information, by the way, and extend support to clinicians who are parents and primary caregivers. Big deal. Some of the other measures: reduce administrative tasks that are not mission critical. So, it's optimizing your EHR templates. I hate that term optimization in that context because it means it can't be made any better. It's like nearly perfect, but at least, streamlining those templates so that they're not redundant. They don't have superfluous information in them, et cetera, et cetera. Offer and promote free confidential sources to support clinicians' mental health. So that sort of a branch off of that other bullet point. Actively encourage clinicians to use their available vacation, PTO, et cetera, et cetera. These are some of the measures that they recommend. The interesting thing, again, we have a discussion at the end of today from 6 until 7. Okay, we'll talk a little bit. We're going to be soliciting your feedback on some of this stuff. And by the way, in some cases, I imagine the organizations either for whom you work or you're aware of that others work for. I'll bet you there's places that are doing some of this stuff. Okay, so I'm not totally cynical. It's just this article is really pointing to its importance. Okay, and you have the healthcare organizations scratching their head saying, I don't know why we can't retain people. And it's just like, well, are you looking at what's out there and are you reading it and are you trying to devise, are you making it a mission critical strategy to retaining your current talent and obviously recruiting additional talent to backfill? And it's got to be a cohesive strategy. It can't be something you do a little bit here, a little bit there. Otherwise, they're not being serious about it. Mitigating burnout, death cafes. I know this sounds really morbid, but what happened was, let me just go into the overview. So preliminary studies suggest that debriefing sessions may reduce burnout. And what this study did was there are what's called these death cafes, where individuals that are doing a lot of terminal weans or they're dealing with death and dying in the ICUs. They're doing, if you will, end of life care, sharing network care, et cetera, et cetera. That what they found is that by doing it's not literally a cafe, but by doing these debriefing sessions, it could be very useful to individuals that are exposed to a lot of death and dying. Well, this study basically took that philosophy, but said, well, it doesn't have to be just death and dying. It could be just related to the whole, treating COVID patients, even ones that don't die, but just linger for very long, the long COVID patients in the ICU, the long COVID patients that eventually get out of the ICU, but they now, are candidates for lung transplants and things along those lines. They've been in the hospital for 109 days, on the ventilator for 82 days, et cetera, just can be wearing. And really, this whole article talked about, these debriefing, structured, professionally anchored debriefing sessions, okay, as an effective tool. And what this particular one looked at, using bi-weekly debriefing sessions facilitated by a psychotherapist, 3 months, or a control arm where they got nothing. And basically they found that the intervention could be very effective in mitigating, some of the stress and burnout. Coping with death and dying, tools to help the respiratory therapist handle frequent exposure. This was a article that was published by Mahan in 2019. And, this talked about more specifically about doing terminal weans. And really, the findings were a vital component of respiratory therapy is managing these terminal weans. Therefore, education, recognition of death anxiety, death stress, death post-traumatic stress are important for respiratory therapists. So understand that we do know that, you know, post-traumatic stress disorder can occur, as I said earlier, because of a single thing, a single traumatic, a witnessed, you know, murder, or just a traumatic event, you know, a rape, a major crime, you know, sort of thing, one thing. It can occur over a long period of time, okay? And it's not an even thing. It's not like, oh, well, someone gets worse and worse and worse and worse over a period of time. That can occur with some individuals. With other individuals, they cope, they cope, they cope, and then they're exposed to an additional stress, additional occurrence. You'll see this in combat. You know, we talk about battle fatigue. It was an old term that was used, where individuals been in battle. They've been in battle for days, weeks, months. They functioned admirably, and nothing was different except there was another battle they were in, and they were just done. So it's not an even, it's not a straight line. It is sometimes it's just this, you got to the point and it was the straw that broke the camel's back. Okay. So that's really kind of like just to kind of frame this whole thing of, you know, this particular one looked at death and dying in terms of terminal weans, but it can just be that, you know, that 97th terminal wean that just was just caught maybe the patient reminded the clinician, the RT of somebody they knew, or it was a circumstance, or it was just something clicked or didn't click. So they really recognize in this particular piece, managers and leaders in hospital must make efforts to provide counseling and education to support the respiratory therapists. Recognition that everybody handles stress differently, and the same person can handle stress differently at different times. These are things that we know. This isn't an Al Heuer thing. This is things we know. Maintenance and marketing of formal clinician brief counseling programs can be very useful. Managing perceptions of, you know, stigmatizing health seekers. In another presentation I give on COVID, I talked about crying. I talked about myself crying. And the more I talk to others that I trust and whatever, people I work with and friends and whatever, is there was a lot of us that were crying in our cars, in the shower, quietly, maybe not even shedding a tear, just crying inside type of deal. But it was, you know, became more open about it. So, you know, we weren't stigmatizing criers. You know, whatever. And what I say is sometimes after I was done with a little cry, I felt a little bit better. So, you know, everybody's different. Peer support groups, you know, education of management on recognizing and responding to stress. That's something that I don't know. I don't know how good of a job that we do on in that, and I don't know how good of a job that our leadership overall, whether it's very high level, from a governmental oversight organization to organizational healthcare organization, of recognizing, you know, how stressful the job has become, and the importance of intervening and having this, you know, well-woven strategy on identifying and addressing these stressors. It's very uneven that you know, it's happening in some places, other places it's not, in other places it's happening a little bit. It's just, you know, it should be the priority. Yet again, these organizations are scratching their head. Well, why are people leaving? They're leaving because they're burnt out, because you're not doing some of this stuff. You know, we have a Zen den. Literally, I talked to Justin. We have a Zen den in a hospital in which I work. Okay, and I almost think it's the leadership wants to say they have a Zen den. Somebody's like, what do you? Can I go to the Zen den if I'm feeling stressed because my assignments do have a Zen den? It's just like it's like nobody told you like how to use it, or is there going to be somebody there to kind of a counselor there? There's nothing. It's just, I don't know, just it's sometimes it's I'm embarrassed for certain, you know, certain leadership teams. It's just, you know, is what it is. Mitigating burnout, recognition, treatment, resilience. So employers, what can be done? You know, support your employees. There's no substitute for people need to feel supported. Your friends, you need to feel supported by your friends. Your friends need to feel supported by you. Your, you know, husband, wife, significant other, whatever the case may be. You know, your colleagues. Everybody needs to feel supported. Okay, and if you feel supported and you get along with your boss, okay, meaning, you know, that's all the difference. Studies show that you'll settle for a little less money if you feel like you're supported. You feel like if you got to go in and, you know, somebody said something about whatever, and your manager going in and they got your back, that's worth a lot right there. You want to keep your employees, support them. Formulate properly resource and promote strategies to treat PTSD and burnout. Meaningful, sustained, well-supported programs. I'd say evidence-based, all these features, meaningful, not just optics, aimed at self-identification, third-party recognition, again, evidence-guided or evidence-based. Provide health insurance coverage for such programs, where appropriate, debrief behavioral issues, in a more supportive and less punitive way. Destigmatize burnout and PTSD, and some of that's happening. Some of it's happening, without COVID and with COVID. Employees, educate yourself. So we own some of, we're the masters of our own destiny. Okay. I will tell you right now, there's been times in my life where I, that saying didn't go so well. I needed the counsel of my friends. I needed the counsel of two of my best friends and my two brothers. I could tell them anything, and they give me some sound advice. On rare occasions, it's been professional help, and it is what it is type of deal. But you're the master of your own destiny. If you feel yourself, like you're kind of on that edge, you do own some of it, and you need to educate yourself on available internal and external services and resources, and try to use yourself. Avail yourself of them. Humility. If you feel like you need help, you got to try to seek it. You just got to put the pride aside. And I'm a macho man, so whatever. But it is in the end. Think of the alternative of decompensating, of emotionally decompensating. Seeking help is a much better alternative than decompensating, and just doing harm to yourself, even by neglect, just neglecting yourself. Stay tuned. Behavior of those around you. Do they seem like they need help? And it's what I say to my students, is you're not entirely your brother and sister's keeper, but you have some responsibility to them. Okay, if it's all about you and what you're gonna, then it doesn't work out. So one of the things I like to see, and I encourage in the respiratory students, and I was with them yesterday and today, and mentoring them, I want to see them work together as a team. I want to see them, I want to see them competing, like a zero-sum game. I want to see them working as a team, helping each other out, learning, helping each other out when they're in clinical, when they're in lab, et cetera, et cetera. Looking at if someone needs, if they're falling behind, I own some of that responsibility as the individual, and those around them do as well. Avail yourself of support and treatment services. Mitigating PTSD. So that's kind of getting more deeper into it. Remember, PTSD it's an actual diagnosis. Social support, it may be a protective type deal. So some evidence suggests that high levels of social support perceived as protective. What we mean by this is this. It means, what I mentioned is, I'm very blessed. Okay. I have a circle of very close friends that I can pretty much tell anything to, even if it was something I screwed up or whatever. And I have two brothers that are my best friends. And, I feel somewhat protected, and a wife who's absolutely a best friend and very supportive. And as I support her as well. Folks that don't have that. And I feel blessed because I know I have it, and at least at this point in my life. And I know that there's people around me that maybe do not. And they found people that didn't have that were not as well protected and were more apt to decompensate and be vulnerable to PTSD and burnout. Group trauma, so focusing on cognitive, behavioral, guided therapy, where it's channeling your thoughts, being in the moment. There's different things that you can do that are again evidence-based, that should be guided by a psychotherapist, a psychiatrist, psychologist, whatever, a social worker, that can be absolutely helpful. Guided self-help, it's not the same thing, but guided self-help can be very helpful. Medications, and I find that basically counseling and medications can offer individuals, some very, very real benefit. Treatments like, don't laugh at, pet therapy. There's different alternative treatments that are out there that really seem like they offer some benefit as well. Immediate intensive treatment if inpatient is needed. So if we become the patient and we decompensate, then there is some benefit to not letting it go long and interceding very quickly and trying to, stave it before the individual falls further, into that crevice. Yeah, so one of the things that I'm switching gears here, because now we're to the point where we identify some of the variables, factors that overall left healthcare professionals vulnerable, ways in which COVID may have contributed to it, but also some of the features and some of the strategies that can be used to ameliorate the burnout and post-traumatic stress. Okay. And I talked throughout regarding staffing, but understand, for any nurses in the audience, the AARC is the American Association for Respiratory Care. Okay. My wife's a nurse, nursing organizations have, similar guidelines, and they really talk about staffing. Account for all activities required of respiratory care is one of the, have a system to do that, because respiratory therapy, many of the things we do are not directly reimbursed, but the productivity, the time we spend doing it, needs to be accounted for. It needs to be collected somewhere so that we can justify our staffing levels. Unweighted metrics such as patient days should not be used to determine respiratory therapy staffing levels. Third bullet, adequate staffing levels decrease the potential for error and harm. Okay, that much we pretty much know. Understaffing respiratory care services places patients at risk for unsafe incidents, mistreatments, delays, again, for badness. Okay, so I'm saying this because this isn't just, oh, well, let's just staff more. This is one of our guiding oversight organizations that's saying these things. We have some guidelines that are out there, and it's critically important that you use some of these resources that are out there. You try to adhere to the guidelines, and if you understaff, there's consequences. And the consequences, if you notice here, they're talking about patients. Consequences on top of that are that you lose staff. People just get tired, get burnt out, and then they're done. The math is bleak. I guess you could argue that maybe a fair amount of this presentation is bleak, but I don't mean it to be. Okay, I don't mean it to be, because there is absolutely things that can be done. And some of those things I've alluded to, some of them I'll allude to in the next few minutes as I wind down. The math, fewer respiratory therapy schools. I'm an educator. I still teach. I ran the respiratory therapy program at Rutgers University for 7 years. I graduated from it, et cetera, et cetera. But we know we have fewer schools, fewer graduates overall, more turnover. Things are not likely to change too fast. Okay, some of the, the specific, results that I pointed to. 10% fewer respiratory therapy programs, 10% fewer graduates, aging workforce, disproportionate retirements, grossly disproportionate retirements, higher turnover, some who've just decided to leave the field altogether. So what to do? Bridging the gap. Few slides on what can we do. So create a more nurturing environment. Millennials and Generation Z demand it. They're like, it just seems like, again, I hear this from my students who are Gen Zs and millennials. They're like, if this gets too rough, I don't know, I'll find another area to do, type of deal. Offer and promote programs targeted at preventing and treating burnout and PTSD. So this is really taking some of the recommendations from the studies throughout this presentation, incorporating them kind of in an ensemble of things that can be done. Offer value-added rewards versus, the other employers in the area. So career ladders, reward and recognition, employee assistance programs, and some of the benefits, offering enhanced, tuition reimbursement, things along those lines. Keep salaries and compensation competitive. Don't show discipline specific favoritism. So, again, I'm not picking my wife's a nurse, love her dearly, but nursing gets, they're much bigger in terms of numbers. So in a lot of organizations, they just get more forcing attention. It's not just focusing on attention, is when it comes to HR, retention bonuses and stuff, they will tend to be, looked at first. RT smaller numbers, and you need to have an advocate there saying, wait a minute, reevaluate and revise, all of the above measures as time goes on. On the demand side, redesigning, how we deliver care. I'm of the belief that we cannot continue to do care the way we've been doing it in view of the shortage of nurses and respiratory therapists. It's going to have to require re-engineering, and things like protocols are just going to, protocols are a must, where, patients that are getting albuterol, can't be an optional thing. Patients that blood gases are ordered on, but there's been no ventilator changes, in the past 12 hours, but the resident wants it. No, if you want, you're going to have to get your attending to order that ABG. We're not going to order it because you want it and the patient doesn't need it. So it's not going to happen. We can't do it anymore. I mean, it's one of the things that, the few managers I know out there, respiratory managers that are very, very strong and experienced, will go and basically say, this is the level of service that we can provide. Okay. When they get real short, they will literally call the nursing manager who's on that day, if it's a weekend, and say, We're short by 3 therapists. I need the nurses, and this is, it's been preordained. It's not just, but preordained is that they go with the nurses, will give the floor care, will give, nebulizer treatments that day, not forever and ever till the end of time type of deal. I'm also saying, I'm not even purporting that per se. I'm saying that we cannot continue to do the job the way we always did it in view of these secular changes, okay? We can't expect, to the first bullet point in this slide, don't expect to do the same with less, okay, or more with less. Remember, Metanebs didn't exist, 10 years ago. High flow nasal cannula was not used widely on adults 15 years ago, whatever. So you have this choice. Oh, gee, when they're eating high flow and then put them back on a BiPAP after they're done eating, and then no, craziness. Manage RT departments, customer expectations, short staff, as I said. Maybe let nursing may be short too. So, that can work. It can work, and maybe it doesn't work. Expand the use of protocol-based care, absolute necessity. Reduce low dividend activities, increase high dividend ones. So manual CPT versus bed CPT, vest or aerobica, things along those lines. There's changes that can absolutely be made. That would be, I don't want to say transformative, but they would be influential in easing certain burdens that are out there and more efficiently using the staff. Take home points, home stretching it here. Burnout's real, it's a real phenomenon. May or may not warrant medical attention. It can, so there's this overlap. It can deteriorate to post-traumatic stress disorder or just traumatic stress disorder. It's not, trauma is still occurring, whatever. It's a dangerous disease requiring medical attention. So PTSD is a diagnosis, it requires medical attention. They're both deleterious to clinicians and the organization for whom they work. COVID-19 definitely made them worse. More will be published in this area in the future, I hope. I think that, the long haul, the effects of COVID on the clinician, we're just scratching the surface now. 10 years from now, I think we'll have greater recognition. I like to think we'll have greater recognition of it, and hopefully greater intervention, because sometimes, people, they endure stress, and it can take 5 years for them to actually start manifesting issues related to their post-traumatic stress. It didn't happen right away. They were compensating in some other ways. They retired, they became disabled, and then all these bad memories came back, and it worsened. Healthcare organizations should, hopefully they do demonstrate structured actions to mitigate burnout and to address post-traumatic stress disorder. Recommended readings, then several of the key ones that we were discussing throughout this presentation that I strongly point you to. And with that, I want to thank you all for joining me in this session today. Hopefully you got something out of it, and hopefully we'll see you again soon. Thank you very much and have a great day. Bye.